How are you going to monitor the tell us?
Monitoring, you would want to do at least 2 to 3 weekly serum ALP or serum phosphate. If the serum phosphate is now less than greater than 1.8,
what units, please?
Millimoles per liter.
So you want to monitor that. Alkaline phosphatase you want to monitor.
Yes.
So what is the normal alkaline phosphatase in a preterm baby? Anyone? Tracy? Have a show? Kitty?
Sorry, Prof. I think it depends on the age of the patient, the gestational age of the patient. If it's like in this case, this patient was delivered at how many weeks, by the way? At 28 weeks. So it should be between 35 and 604 in a child who's below 27 weeks gestational age.
35
to 608. The range. Yeah. I'll send a picture on the group.
Yeah. No, I think we must know what would be the range in a preterm baby, because that's where we're worried about. And of course, what you want to monitor is the trends in the alkaline phosphatase. Is it coming down or not? Okay? Right, carry on. Anything else?
That was the case up to today. So I thought of talking about recurrent pneumonias.
Okay.
So the definition we have talked about, but there needs to be resolution of symptoms clinically and radiologically for you to say there is a recurrent pneumonia. Unlike persistent, where there is ongoing symptoms and
yeah. So Marian, what I'm a little concerned about is you said a clinical or radiological resolution.
Yes.
How long does it take for the radiological changes to occur in pneumonia?
Radiological changes of pneumonia usually lag behind the clinical signs. Resolution, the clinical resolution. So within about 4 to 6 weeks, that's when you can see the radiological changes if there is going to be resolved.
That is, okay, good, carry on.
So in a patient with, I think you need to enlarge your screens, sorry for the small table. For a patient with recurrent pneumonias, it's important in the history to ask about the pattern of the...
Where did you get this, this table from?
There is an article in the African Journal of something, where they talked about recurrent pneumonias. I can't remember, but I have the article.
Good, I think we'll send it around. That's a good table. Very good. Carry on. That's good.
So there needs to be, if there is a cough, how long the cough has been for, and the pattern and the progression, and if there is any positing of feeds suggestive of maybe gastroesophageal reflux and paroxysmal cough, especially in patients with foreign body or even pertussis, because pertussis it can have a prolonged course. A patient can present with
sorry, Marian, I just want to say something. You have put GORD, gastroesophageal reflux disease. You must separate this from reflux, occasional reflux versus disease. You agree?
Yes, because disease now has failure to thrive and complications.
Anemia, deficiency, all sorts of things happen. Yeah, great. So please remember that. You must separate the two. Carry on.
we have seen, or there have been cases of cystic fibrosis in the Black population, even in South Africa. So it's important to ask about the type of stool and also whether the patient passed meconium, whether there was delayed passage of meconium. And the birth history and the perinatal history is very important, especially patients who then get bronchopulmonary dysplasia and also cystic fibrosis, something to think about. And one of the most common causes of recurrent pneumonia is environmental. It's on the next slide. So past medical history, looking at what's the previous admissions were like with the pneumonias, and to relate it with the current pneumonia, and any patterns that can be seen, especially with patients with allergic rhinitis or even recurrent viral-induced wheezing. They might come in as looking like a pneumonia, but it's actually allergy related. So it's really important to get the history of atopy and history of having had wheezing before. And then the other associations, patients with primary immunodeficiency or even secondary immunodeficiency can present with recurrent pneumonias because of their immune status. So it's important to ask about the drug history and any other comorbid conditions. And then on the, and then the most common cause in our setup, not common cause, one of the things that we usually forget about is the environmental exposure, whether at home or in the community. My father was smoking as a risk factor for recurrent pneumonias, so it's always important to ask about that. And also TB, symptoms of TB, both in the caregivers and also in the patient, and to always do a symptomatic TB questionnaire for the caregivers.
Okay.
And then on examination, it's important to look at whether there is whether there is anemia, because anemia associated with recurrent pneumonias, we're thinking more of a chronic cause, maybe TB or other chronic infections, and the presence of clubbing, so all those things, the JACO needs to be looked for, and morphological features. Patients with maybe Dye-George syndrome, they can have dysmorphic features, which you can see on examination. They're at risk of getting recurrent pneumonias, maybe from cleft palates, or and then patients with Wiskott-Aldrich syndrome as well. They're usually boys with eczema. So those are some of the morphological features that you can look for, or even ataxia telangiectasia, you might look for those features. And also look at the respiratory inadequacy, and also observe during feeding, because sometimes some of the reflux can actually happen whilst you are watching, and confirm the history that you have gotten. And it's important to look at the growth and development. And we always, I usually used to forget about the ENT. It's important to look at the ear, nose, and throat, especially in patients with cystic fibrosis or even other anatomical abnormalities. They can get recurrent otitis medias and turbinoids and inflamed turbinoids in patients with wheezing, and also polyps in patients with cystic fibrosis.
Marion, is there anything you want to tell me about the examination of the mouth and the throat, especially the mouth, which also cause recurrent pneumonias?
To look for a cleft palate.
Yes. Remember that. Always look for the cleft palate in its palate. Recurrent pneumonia. Okay, good. Carry on.
So after examination of the respiratory system, it can be localized disease or multi-lobar involvement. So investigations can be according to those flow charts, and you can look and follow. So sometimes if it is unilateral, you might be thinking of a foreign body or even a mucus plug, and you can do a bronchoscopy or a chest X-ray, or ultimately a CT scan if all the other investigations were normal. So it's not every child who has recurrent pneumonias who end up having a bronchoscopy. So you need to tailor make it's according to the patient how they're presenting and what your differentials are. If it's multilobar, then you need to check. Always remember the immune system. It could be a primary immunodeficiency or even a congenital. But not to forget that heart failure can present with recurrent pneumonias, and the allergies or asthma can mimic. And you might think it's a recurrent pneumonia, but probably it's just an allergy manifestation. And complications of pneumonia, such as bronchiectasis, can present as just recurrent or persistent pneumonia. Yeah, I think we can go to the next slide. We have 10 minutes left. Yeah, so going back to our patient, thought of looking at the preventative measures in preterm babies from getting pneumonias. According to GAP-D guidelines, breastfeeding is one of the preventative things that you need to do, and also exclusive breastfeeding for 6 months, and then continuing breastfeeding with adequate supplementary feed. And routine vaccination at chronological age, it's really important to emphasize that, especially at the primary healthcare setting, where most of these preterm babies are not given their vaccines according to chronological age. They actually wait for weight to be above a certain cutoff. And there has been talk about Phosphatase being given to women who are pregnant, especially in the between 26 to 36 weeks of gestational age, and all the other close family members who have a preterm baby in their house. They should get Phosphatase vaccine, especially if they're more than 19 years old. The influenza vaccine should also be considered in patients with who are preterm, but it should be given for those who are greater than 6 months. So for those who are less than 6 months, it's important to give the immediate family members influenza vaccine during the influenza peak to decrease them getting the infection. And the other thing is immunoprophylaxis with pembrolizumab for patients with who are at risk, preterm at risk of getting RS. So it's important for them to get, but it's expensive. So I think it's tailor-made to the case, to the patient that you would ask them. Thank you.
Thank you very much. I think this is very interesting. I think we need to. What about bronchopulmonary dysplasia? Do you think it's playing a role?
The definition of.
No, somebody said they're associated with recurrent pneumonia and vitamin D deficiency. Yes, it is.
Yes, it is.
Yeah. So bronchopulmonary dysplasia, you think that's playing a role, or may play a role in recurrent pneumonias or unresolving pneumonias?
Bronchopulmonary dysplasia.
Distress, yeah.
Yes, it's a common cause of recurrent pneumonias or even persistent pneumonias, especially in the first year of life. But the problem is they need to meet a specific criteria for that definition, and but it is a very common cause.
Okay, so everybody, please, you must identify keywords here which we've talked about, and unless Marion, you want to make a summary of the keywords, and everybody must look up all those things. Okay, so Marion, can you summarize the keywords and send it around?
Right.
and read. And tonight I want to hear what is the optimum therapy for osteopenia of prematurity. Tonight. Okay? Thank you very much. If you want other sessions, please let me know. We can do it other part of the week as well. No problem with